Good evening, doctors. On behalf of Harmonica Acumentis, myself Shubhojit Mukherjee, SBU Head, Sales and Marketing, welcome you all. Welcome all doctors from India and abroad, because I come to understand that many doctors outside India are also watching this. Before I quickly get over to the session, let me take the privilege of introducing my company. My company is called Acumes Drugs and Pharmaceutical Limited. This is the parent company. Acumes is the largest contract manufacturing pharma company of India, and the organization deals in the manufacturing and export of formulations in a wide spectrum of dosage forms and therapeutic segments. And currently, Acumes is currently supplying to almost all Indian and multinational pharma companies across the globe. Next slide, please. A lot of products that doctors you prescribe are being manufactured at our Acumes plant. And in fact, previous slide, yeah, the division which we represent is called Harmonica, brings back harmony to life. And at Acumentis, we have 9 strategic business units: women's healthcare, cardio, diabeto, orthopedia, derma, and of course, the general segment. At Harmonica, we are a division that serves women's healthcare through gynae, obstetrics, and IVF. And of course, these are the therapies we deal in: medical management of fibroids, medical management of endometriosis, medical management in PCOS, and of course, the IVF therapy. This is in a nutshell about my company, Acumes Drugs and Pharmaceutical Limited, and Acumentis, which is the sales and marketing wing of Acumes Drugs. I now take the privilege of introducing Dr. Jaideep Malhotra. Can we have, yeah, Dr. Jaideep Malhotra, without whose help the program would not have been possible. Let me introduce her, though she needs no introduction. Dr. Jaideep is Director, ART Rainbow IVF. She is the chair-elect REI FIGO committee, for which we Indians are very proud of. She is the President SAFOMS, past President FOXY, Aspire, ISAR, IMS, and ISPAC, President Indian Society of Prenatal Diagnosis and Therapy, Vice President, Indian Society of Aesthetic and Regenerative Gynecology. She is the Regional Director, South Asia, Ian Donald School of ESG. Dr. Jaideep is Professor, Dubrovnik International University, Croatia, Editor-in-Chief, SAFOG and SAFONS journals and many books, member of FIGO Committee of Reproductive Endocrinology and Infertility and FIGO Working Group on RDEH. Dr. Jaideep is recipient of honorary FRCOG and FRCPI. She has won Lifetime Achievement Award in ISSRF and Amar Jwala Gaurav Samman Award. Dr. Jaideep features in India Book of Records and World's Book of Records for Swasth Siddha, and of course awarded by Honorary Governor of UP, Sri Ram Nayak Ji, the Indumati Javeri Prize. Over to Dr. Jaideep. Madam, you are mute. Just unmute.
Thank you, Shubhajit. And thank you so much. And a very good evening to all of you from the FIGO REI committee. Welcome to this wonderful masterclass on endometriosis. As we all understand, endometriosis is a very enigmatic disease. And at every point of time, whichever age group, a girl may suffer from endometriosis, there is always a dilemma, whether it's diagnosis or management or even long-term implications. And I'm very, very happy and very proud and very thankful to our chair of the REI committee of FIGO, Yvonne Days, who gave us this opportunity to conduct this 6-module program on the various aspects of endometriosis. And I'm sure all of you who have been connected with us for all these months, because we have only one master lecture every month with some very key speakers from all over the world. And you've already gone through the first 3 talks which were delivered. Can we just go back, Suhas, which were delivered by Linda Judice, the first very, very important talk on endocrine and environmental disruptors affecting reproductive health, and with special emphasis on endometriosis. Then our second talk was on challenges in understanding the pathophysiology. Again, a very huge subject which was beautifully dealt with Dr. Mary Louise Hull from Australia. And last month we heard none other than Dr. David Adamson from US on dilemmas in diagnosis and management of endometriosis. And today we are going to hear from yet another awesome speaker from Ireland, a very, very dear friend, Dr. Edgar Mocano, who's going to talk on managing endometriosis in infertile patients. Again, it's a catch-22, what to treat, the disease first or the infertility. And next month, you are going to listen to me on ovarian stimulation protocols in endometriosis and ART. And we will end this masterclass session in November by controversies in deep endometriosis and infertility by Rui Ferriani. So we are looking forward to each one of you really enjoying this masterclass, which I know that all of you are enjoying. And please keep your questions posted, because we have some very eminent chairpersons and also a course coordinator, along with our speakers, who will address all your queries and the myths or any kind of understanding which you require for the disease, its management or diagnosis. And I'm very, very happy here to introduce my very, very dear friend, Yvonne, who is the current chair of REI committee of FIGO, and who has led us in these last 3 years in a wonderful, wonderful way. Yvonne is a professor at the Newer Granda Military University Department. She's also the head of the Department of Obstetrics and Gynecology and Human Reproduction at the Hospital Militar Central at Bogota, Colombia. She's also the scientific director of medically assisted procreation fertility unit of Mali Clinic and the past president of Colombian Federation of Obstetrics and Gynecological Societies. And she's the current chair, as I told you, of FIGO REI committee, and also the corresponding member of National Academy of Medicine. Yvonne, we're looking forward to hearing from you.
Thank you, Jaideep, and for our committee, Reproductive Medicine, Endocrinology, and Infertility. Is very, very glad to be here with you for this important program, Masterclass Endometriosis. FIGO to continue to the education around the world for all reproductive medicine in our committee is very, very important. And congratulations for to be here, Edgar Mocano. Edgar Mocano is our past chair of our committee. I hope the assistant to be provide these excellent speakers. Thank you, Jaideep, and for FIGO, thank you very much for being here.
Thank you so much, Yvonne. I think your presence and, I tell you every time, because we are doing this program and sometimes these are very unearthly hours for you, and you have made it especially possible to be with us. And I'll be ever indebted to your commitment towards, the course. Thank you so much, and also thank you for helping us conduct this course in the most positive manner. I move on next to introduce our course coordinator chairpersons. We have Dr. Pratap Kumar, whom you have all met for all the 3 past lectures. Everyone in India knows Pratap, and all over the world also. Pratap is head of the Department of Reproductive Medicine and Surgery at Kasturba Medical College, Manipal Academy of Higher Education, a very committed and a dedicated teacher who is so popular and loved by all students and the teachers of students also, Pratap. We all love you because you're really, really an amazing and awesome person. Pratap has been the National Vice President of FOXY and is also an inspector and examiner and advisor for the National Board examination. As I said, he is really, really committed. He has, several publications and he has written several chapters and books, and he's always ready for anything. And thank you, Pratap, for being here. We are looking forward to a lot of good interaction from you. And I move on to our next chairperson for this talk, Dr. Naren Malhotra. I'm sure again everyone knows him. Welcome, Naren. Naren is the director of ART Rainbow and Rainbow IVF. He's the managing director of Global Rainbow Healthcare. He's the director international relations of SAFOG and is the current president of INSARGE, which is an aesthetic and regenerative gynecology organization. He also is a professor in Dubrovnik International University. He has held many posts. I can go on and on. Again, a very committed soldier, which India has, always ready and always positive to move forward with any job which is, entrusted to him and performs well. So thank you for being there, Naren. I'm really looking forward to both of you and Pratap conducting a great interactive session. Now,
thank you, Dr. Jerry.
To introduce our speaker of the day, Dr. Edgar Mocano. I have known Edgar for quite a long time now. He has been, in the past chair of the REI committee of FIGO, and that is where my introduction with him started. A very, very organized person, and he's really amazing. He holds a certificate of specialist in OBGYN. He's from Dublin, Ireland, and he has immense interest in a lot of things: reproductive medicine and surgery, diploma in ethics of medical research and biotechnology from Kiel, UK. He also holds a research doctoral degree from Trinity College, Dublin, an FRCOG diploma in digital marketing. I didn't know that, Edgar. Consultant obstetrician gynecologist and an honorary senior lecturer at Rotunda Hospital. I have visited this beautiful hospital with a lot of history and so many things to learn from this hospital. Very well organized and run, where Edgar works. And Edgar is the president-elect of International Federation of Fertility Societies and immediate past chair of FIGO REI committee, and also the chair of ESHRE Clinical Science Poster Awards Committee. And we are really looking forward to hear you, Edgar. We know that you have had, many publications and you have delivered many talks, but this one is special because this one is like a double-edged sword. And I am really eagerly looking forward to hearing you how we'll manage endometriosis in infertile patients. I'm sure it's going to clear a lot of doubts in our audience mind. The stage is all yours.
Thank you very much, Professor Malhotra. Professor Diaz, a pleasure being here. Thank you for organizing and the invitation. And Professor Kumar and all the audience, I look forward to the interaction with all of you this evening. And thank you for participating at a late time of the evening, probably taking time from your families. So having asked to talk about endometriosis and what should we do if endometriosis is diagnosed in an infertile patient, I might start with my disclosures. I have no conflict of interest related to this talk. And as already mentioned, I do actively participate in some regional and global organizations. I would like to bring to the fore 4 learning objectives. The first one is a few words about diagnosis. Next, to dwell on the initial advice to patients once the diagnosis is made. How should we approach a decision-making in certain circumstances? And then, what are the links between ART and endometriosis, and what should we do before we advise our patients to embark on ART, IVF, or ICSI. My slide on diagnosis is very succinct because you would have had the eminent Professor Adamson talking about diagnosis, as he is the one that initiated the staging criteria which are crucial for diagnosis. Yet, my perspective here is more clinical in terms of seeing the patient in your office rather than having the patient under anesthesia and under a laparoscope. So clinically, we base our diagnosis on symptoms. Everybody knows dysmenorrhea or dyspareunia, painful intercourse, family history, and of course examination. And many times we don't see anything on abdominal examination, yet vaginal examination can reveal certain clues, particularly seeing nodules in the posterior fornix. Ultrasound, and I think extensive use of ultrasound in reproductive medicine is something that all of you practicing infertility are used to, and ultrasound will give you good clues about the presence of, for example, up at the top right, the presence of endometriosis in the ovary, the endometriomas, either a single one or two endometriomas, and the picture of kissing ovaries that is clearly seen here in the middle of my slide. At laparoscopy, this is a picture that you really dread seeing because you already know that this is very advanced endometriosis. Prognosis for these patients is poor. Yet this picture does not show the fallopian tubes, which are also crucial in terms of what to advise the patient. And of course, if somebody has the facilities of having MRIs before surgery, one could explore the extent of disease and how complex the surgery will be so they can plan appropriately the surgery. I thought that this picture, which is indeed not mine, this picture was a very interesting one showing 3D ultrasound where you can see the cervix, the vagina, the bladder, the rectovaginal septum and the posterior fornix, and a lesion here in the posterior fornix quite clearly evident. So I think that 3D, 4D ultrasound will have a role to play in the near future in terms of diagnosing endometriosis. There's no doubt, and I don't need to tell you, that endometriosis impacts fertility. So when you do a laparoscopy and you see this picture on the right, you know that very little can be done in terms of spontaneous conception without significant intervention, which I will detail further. So it alters the pelvic anatomy as seen, and also alters the pelvic fluid physiology, affecting the ability of the fallopian tube to interact with the ovary for ovum catching, so to speak. It does impair implantation at molecular level, and this has been known for a long period of time, yet we have no active intervention in this regard to improve matters. So what should we advise our patients once we made a diagnosis, let's say clinically or with ultrasound? I could summarize in this drawing or flow chart that comes from UpToDate everything that I will discuss in the first part of my talk. But let me just take you through it. I mention it here as it is a source where you could seek knowledge and maybe be able to create a pathway for advising your patients. I would first say that we should not forget the reason why the patient is there. It is an infertility situation as opposed to an endometriosis-only situation. The couple are seeing you to understand what can be done in terms of fertility, and you have just diagnosed endometriosis. So one should progress with investigating the couple like there's no endometriosis initially. So ovarian reserve in the way of AMH, hormones in general, things like FSH, LH, estradiol, if you still do them. I don't, unless there's a specific reason, like amenorrhea, and then prolactin thyroid function tests. Health issues like immunity to rubella and a negative smear test, and then nowadays, very important, vitamin D, B12, folic acid, and maybe a full blood count, particularly in India where you might have situations with severe anemia and so on. And of course, don't forget the male. There's nothing worse than treating the woman to the full offering her all the investigation, surgery, suppressive therapy to find out that the man has no sperm. So investigating fully the couple from the beginning is an excellent starting point. So what criteria would you base your advice and a decision afterwards? Well, firstly, think about the diagnosis of infertility. Have we identified a significant male factor? Is the woman of a certain age, young, middle age, or a bit more mature? Did she have previous surgery? What is the stage of the disease you've diagnosed? What are the previous surgeries? Did she have a cystectomy? Did she have ablation, laser therapy for endometriosis? What treatments did she receive? And very important, are there treatable causes of infertility? So if the endometriosis is mild and other treatable causes of infertility are present, for example, anovulation, for example, a hyperprolactinemia, for example, a mild male factor that can be treated with alterations in terms of stopping smoking, losing weight, or reducing the alcohol intake, then they should be the first step. So, of course, we need to ask ourselves, when is IVF the choice? Well, if severe male factor is present with cryptozoospermia or severe oligoastenoteratozoospermia, IVF in the form of ICSI will be indicated, considering that the woman also has a diagnosis of endometriosis. If the female has a very low reserve, particularly if she has an advanced age, and consideration should be offered for IVF. If she has severe tubal disease due to endometriosis, as you will see later, there's little point in insisting on spontaneous conception. And of course, the more severe the endometriosis is, the more this couple should consider IVF. I might say from the beginning, and acknowledging that India has absolutely superb gynecological surgeons. I've witnessed it myself. I've been to India 3 or 4 times to date, and you have a very good, highly trained laparoscopic surgeons. So the first surgical episode is crucial. It will explain the symptoms and diagnose and stage the endometriosis. It will also allow treatment of endometriosis. It will reach a so-called final diagnosis from the perspective of endometriosis, but also female fertility, and it will allow planning of the post-surgical interventions. So if surgery has been done and one is content with what they have seen and done for the patient, should women diagnosed with endometriosis receive suppression therapy of the hypothalamic pituitary ovarian axis? This Cochrane review, published in November 2020, looked specifically at pre- and post-surgical medical therapy for endometriosis surgery. And the authors, looking at 11 randomized controlled trials, concluded that pregnancy rate is probably increased with post-surgical medical hormonal suppression compared to surgery alone. And you can see there's a 20% increased likelihood of a pregnancy establishing. And number of patients that this particular Cochrane review looked at is 955, so nearly 1,000 patients. And if you'd like number, it suggested that the chance of pregnancy following a no therapy after surgery is 34%, but if medical therapy is added, the likelihood of a pregnancy increases to between 35 and 48%. So should we use medical therapy and suppressive therapy? I think there's some evidence that we should use it for a short period of time. We have to remember these are patients that want a baby. They do not attend just for endometriosis on its own. So if we establish that IVF is not the immediate first choice for this couple, how do we judge what exactly we should do? And I confess I did not see Professor Adamson's presentation, but I will have no doubt that he would have discussed the endometriosis fertility index. This is the second baby of his, and he published this paper many moons ago, and he validated it on a large population in his own practice with 800 consecutively diagnosed and treated infertile patients with endometriosis. And he created this index in the hope of helping making a decision after surgery. And what does it look at? It looks at age, duration of infertility, pregnancy history, has the woman had a pregnancy before or not, the functional score of the fallopian tubes, and I'll detail that in a moment, the health of the fimbria and ovaries, and also the severity of endometriosis and the lesion scores according to the initial classification of endometriosis. So if you presented this, please accept my apologies for repeating it, but I find it extremely helpful in terms of everyday clinical practice. It is, and it should be, with your patient charts when you go to theater, if you find endometriosis, to look towards establishing this score. So here, historical factors like female age, 35, younger than 35, 2 points, older than 40, 0 points. Years of infertility, obviously the shorter the duration of infertility, the higher the points that are added. Previous pregnancy, if the woman had a baby before, she's more likely to become pregnant again, so score of 1. And then the surgical factors like the list function score, which are detailed here on the right-hand side, looking at fallopian tube, fimbria lens, and ovary both on left and right, and creating a score, and then adding the endometriosis score and the total score in the end. So the idea is that the highest the score is, the better the prognosis for this patient. And of course, you wonder, how do you establish a number here? The scores are here. Absent or non-functional fallopian tube is a score of 0. So that's the bottom, rock bottom. And if the tubes look normal, the score is 4. So that adds towards a higher score. And for the ones that do not like paper, but like to use modern technology, like, let's say, mobile phones, they also have a website that is present up here, https endometriosis.efi.com, where you can live input the information that you derive from the findings of your surgery. And I'm not going to repeat, but you can see age, years infertile, history, date of surgery. And by clicking next, the machine takes you through all the steps. Here's the fallopian tube. Does it look normal? It's very easy. You have the score description here. Highest score 4, no injury. Click here, tubes are healthy, we're moving on. If the tubes are absent or non-functional, score is 0, so when you click here, score of 0 is added. And this is the description of how to judge if it's mild, moderate, severe dysfunction for all 3 organs. And we keep going, peritoneum and ovaries. You see here once again, peritoneum, ovaries, superficial deep lesions. And in terms of ovarian cysts, anything less than 1 centimeter or a very large cysts here. And once you click the Submit End button, you will receive a score like so, which I think is very intuitive, and it's a beautiful tool to offer your patients. Because if you've ever been at the receiving end, being a patient, you'd like your doctor to somehow quantify and justify the advice that they're giving you. And this is such a useful tool in showing a patient, based on what I've seen and what I've done for you during the surgery, your score is, let's say, 7 or 8. So that will mean that you, after 6 months, you have a 20% chance to become pregnant. After 1 year, 38, and after 2 years, 57. Not that many patients will wait 2 years after this surgery. But you can see these figures again on this green curve, and it could be, of course, anywhere depending on what your findings were during the time of surgery. So the higher the score, the more likely this couple will conceive. And this is a follow-up after 36. I find it extremely useful tool. So let me take you back just one step. You've been practicing in this field for many years, and maybe your previous algorithms look like that. I found stage 1 or stage 2 endometriosis. I treated it surgically with argon laser. There's no male factor present. The woman is ovulating, so we could try timed intercourse if they're trying for less than 18 months, if the female is younger than 37, and if they're willing to continue trying. Or she's not ovulating, we have a good reason to intervene. We apply stimulation either with antiestrogens or aromatase inhibitors, or directly with gonadotropins, and advise IUI, for example. Or there might be a mild male factor where you still consider IUI because the prognosis is so good, as I've mentioned, stage 1 or stage 2. For stage 3, it's a bit of a gray zone, or used to be a gray zone. So treat it surgically, maybe an endometrioma. Use some GnRH analogs. I've mentioned it in my previous slide. They appear to be of help. So use the analogs for 3 months. There's no male factor. Consider FSH and IUI for maybe 2 or 3 months maximum, and then move for IVF. Or if the female is of an advanced age, maybe move towards IVF directly after the GnRH analogs have been used. And then stage 4, this is really frozen pelvis, no chance of natural conception, where IVF therapy is obviously immediately indicated. So this used to be sort of criteria in our minds, but how did we really convince our patients that we believe this is the best for them at that time? So I think we have now a more scientific basis to create a better pathway for our patients. So I'm coming back to the EFI. Okay, Professor Adamson's 800 patients are of value in California, but do they apply anywhere else? And can this be validated in different circumstances? So this is the group of Thomas Doig, who used to work at the University of Leuven, and very keen and extremely interested in endometriosis. And the question that his group asked was very simple. This is published in 2013, is if we take all patients that we operated on and look at the severity of endometriosis and try to see how accurate is the EFI staging system for predicting non-IVF pregnancy after the surgery, what can we conclude? It's another way of validating this, but in a different population. So he published this paper on 233 patients with mild to moderate endometriosis 75, severe 158, and there was a 4-year follow-up. And this looks like a very busy slide, but don't get too concerned about it. I will explain the message here. So you can see here the number of patients as the total number of patients, 233, and vast majority had a very good EFI score. That means they had minimal disease, they had an excellent prognosis to conceive, and then 7, 8, very few had 0, none 0, none 1, and only 3 patients had a score of 2, which would have said go for IVF. So the conclusions of his research show that for each increase of 1 point from 0 to 10 in the EFI score, the relative risk, I would call it the relative likelihood of becoming pregnant, increased by 31%. And even more important, the least function score, which assesses the tubal ovarian function, was found to be the most important contributor to the total EFI score. So is this fallopian tube fimbrillant in close proximity to the ovary, and can this mechanism of ovulation and catching of the egg by the fallopian tube or aspiration of the egg function appropriately, was probably the most important element. And then you always worry about these cumulative pregnancy rates and how they're presented, but this graph really struck me as a very important graph, which you can dismiss very easily. So I'll take this circle back, and you can see the lower colors here, dark green, and so on, are all in the bottom part. So as the EFI was lower and the severity of disease was higher with increased impairment of different anatomical factors, or the woman had no babies, or the woman was trying for more than 3 years, or the woman was older than 35, the likelihood to conceive did not increase too much. In fact, it never went over 20 to 25% after 4 months or maximum 6 months. You can see it's all straight lines. So you could have waited forever. This woman would have not conceived spontaneously. This is spontaneous conception. Similarly for this group, similarly for the dotted one. So for that reason, I thought that this moment in time, somewhere here between 4 to 6 weeks, is critical. But if a patient does not get pregnant after 4 months of trying with quite a lot of endometriosis, there's no point waiting. Far better to send them for IVF. And I was truly impressed by how this curve continued to logarithmically increase the likelihood of a pregnancy if the patient had a very high EFI score. And it's very good even for an EFI between 7 and 8, which even after 12 months, the likelihood to conceive increased constantly. So I found that extremely helpful in clinical practice to advise my patients to say, look, you're on the red line, keep going, don't be afraid. Or, I'm sorry, you're on the black line here or on the green line after 4 months, there's absolutely no point in continuing trying, leave it be. Or, you're on this black line, this is absolutely zero, I don't know why any reason at 4 months somebody jumps from there to there, but move on with IVF. So the second question that comes to mind is, while the first paper that I've just showed you looks at all stages of endometriosis, there are very rare papers that look at moderate and severe endometriosis exclusively. So this paper that was brainstormed maybe in California, but was delivered from Australia, it was a retrospective analysis of treatments performed in Australia in a university hospital over 5 years, looking at similar numbers, 235 patients. And this is the classification for moderate and severe endometriosis with a score of over 16. So the first conclusion was that 63% of women had a live birth following surgery. This is moderate and severe endometriosis. And 94 or 64% of them without IVF. That was very impressive data that I would read. And here, if you would like to see, there's a life table estimated cumulative non-ART and overall birth rate that did not change if the figures were very low. You can see the EFI scores between 0 and 6. There's no change after the first year. So that it's absolutely futile to offer these patients continued support for spontaneous pregnancy. And you can see that if you move these patients into ART, you offer them very decent likelihood of conception, 49%, 53% of them, 38%. So to conclude some of these papers, this group from Australia, once again, Ben Moll and Neil Johnson, looked at interventions for endometriosis-related infertility and performed a systematic review and a network meta-analysis having clinical pregnancy rate as the endpoint. So he looked at the effectiveness of different treatment options for women with laparoscopic proven endometriosis experiencing infertility. And the aim of this review was to best identify the ideal strategy. I'll skip this one. It can be a little bit difficult, this network meta-analysis, but you can see the larger dots are the most important interventions like surgical laparoscopy, and GnRH alone, and so on. So if you look at the flow of the meta-analysis, there are 26 studies left after thousands of studies in the database, and surgical laparoscopy increased the likelihood of a clinical pregnancy. You can see here 63% increase, as did the GnRH agonist use, 68% increase. So he concluded that in women with infertility and surgically confirmed endometriosis, surgical laparoscopy alone and GnRH agonist alone increased the odds of clinical pregnancy compared with placebo. Ladies and gentlemen, what about IVF? Is really IVF the one and only treatment that we should consider for these patients? I would argue not. The outcome of IVF is affected by the presence of endometriosis. We know that for a long time. This study from Kurt Bernhardt and Christos Koutifaris from 2002 looked, it was a meta-analysis of 22 non-randomized studies looking at the chance of achieving a pregnancy. And the odds ratios were halved in women with endometriosis when compared to women with tubal infertility. They also showed a decrease in fertilization and implantation rates and a significant decrease in the number of oocytes retrieved for women with endometriosis. Pregnancy rates in women that had severe endometriosis were significantly lower compared to the ones that had mild endometriosis. So even within the endometriosis spectrum, the more severe the endometriosis was, the lower the pregnancy rate was. I draw your attention to this study from a group in Ghent. It's Petra de Suter's group and Kelly Tilleman, and they looked at impaired implantation in endometriosis compared with couples with male subfertility after transfer of equal quality embryos. So these are male factor endometriosis, no endometriosis, matched quality of embryos overall, 118 cases. Women that had no endometriosis had a 2.2-fold higher likelihood of a clinical pregnancy, ongoing pregnancy, and 2.5-fold increase in live birth. If you look at systematic reviews and meta-analysis, 27 observational studies published in 2013, nearly 9,000 women, the same figure is evident. Fertilization rates were reduced in stage 1 and 2, relative risk 0.9, decreased risk of implantation rate and clinical pregnancy rate in women with stage 3 and 4 endometriosis. So it's clearly evident that IVF in itself might result in a pregnancy but cannot overcome the issue of endometriosis and the impact upon quality of eggs and so on.
Dr. Edgar, can I interrupt? Your power is about to go. Please connect the power on your laptop. We can see the notification.
Oh, I see. Okay, thank you. I'll move on my laptop if you don't mind, just to check out what's happening. It must be that electricity is in short supply in Ireland today. I was very good in terms of connecting, but I don't know why this has done this. Thank you so much for your patience. Thank God we have a normal life. We're not robots. Okay, so thank you for that.
Yeah.
We're back here. So can anything be done to maybe improve a little bit the likelihood of pregnancy after IVF? So long pituitary downregulation is something that can be considered. This is the long protocol with the GnRH downregulation. This was the initial systematic review by the group of Velasco and Salam. And you can see here, this was published a long time ago, 2006. There were only 3 studies at that time, and the outcome of their meta-analysis was very clear in favor of using GnRH agonist versus no agonist before IVF. And you can see both the oocyte number was double in women that used GnRH agonist, but also the pregnancy rates were 4-fold increased. So I was intrigued to see that the same group decided to repeat this, and this was published in November 2019. This is 13 years later, and as you can see, disappointingly, their difference was very, very small, only 13%, and more so, you can see that the confidence interval crossed 1, so there was truly no benefit in using the GnRH agonist prior to IVF. So this review raised important questions regarding the merit of long-term GnRH agonist therapy compared to no treatment prior to standard IVF in women with endometriosis. And they also say, contrary to previous findings, we are uncertain as to whether this treatment impacts on the live birth or indeed the complication rate. So we're still left in a bit of limbo in this regard. So ladies and gentlemen, I covered for you today some aspects of diagnosis, the initial advice that one should offer patients, how a decision-making tree could be built up, the old and the new way, the tools available and tools that are built up prospectively live as you investigate the patient and are able to quantify why you're giving certain advice. And I don't need to convince you that endometriosis impacts ART and what we could do to make things better. I would like to summarize that we have a duty to determine the cause of infertility and not to assume it is endometriosis only. We need to determine what to do depending on the age of the woman, her symptoms, the severity of endometriosis. We have also a duty to explain possible management options based on findings and decide on the appropriate management of the patient. I believe the EFI has made allowed us to make great progress in diagnosing and guiding the patients, and I think that there is still a significant role to play for offering IVF early but also counseling accordingly, because there's nothing worse than advising women that IVF will solve all the problems when in fact we know that women with IVF have a lower likelihood to conceive. So to conclude, endometriosis is here to stay, and I think it is a silent sufferer. And this is why I said yes to the invitation, because I believe we diagnose it late, very late. And I think we failed to date in creating sufficient awareness. Could you understand how many women around the world, young girls, adolescents, young mature women, suffer with endometriosis in silence, never to see a doctor, just believing that it's normal to have painful periods? I think it is our duty to tell them it's not normal to have painful periods. Please see a doctor. I think there's a lot of work that remains to be done, but unless we talk among ourselves, unless we discuss it with our patients, unless we go out and create programs like this, and also support the dissemination of a message through our representatives like FIGO, very little progress will be made. I'm giving you a few sources that you can use in your daily practice. The American Society for Reproductive Medicine have a practice committee on endometriosis and infertility. ASHRAE have produced a guide. It's just being reviewed again now, management of women with endometriosis. There are obviously the World Endometriosis website, endometriosis.california, and there's a endometriosis.org website that also cares for women with endometriosis. And before I say thank you, or after I say thank you for listening to me and looking forward to the session of questions and answer, may I just remind you, this being a FIGO initiative in collaboration with your Indian colleagues, that the FIGO World Congress is between 21st and 28th of October 2021, and we have quite an exciting overall obstetrics gynecological program. So please consider taking time to attend. And as already been mentioned, I do have a role in the IFFS, and this is an international federation of fertility societies. And as my talk was about fertility, may I also draw your attention that next year we hope to have the first live, on the ground, person-to-person networking Congress. We have a Congress every 3 years, but the 24th Congress will be in Athens, which is not very far from India, and it's on the 3rd and 6th of April 2022. So FIGO in October, and the meeting in Athens next year in spring. Thank you to all for attending, and I look forward to our discussion.
Jaideep, you want?
Yeah, thanks, Edgar. It was a crystal clear presentation as always. We expect no less from you. And there were a lot of take-home messages, I'm sure, which all the people who are listening to, especially our young postgraduates, are definitely going to benefit. And I'm sure there are lots of questions which I can see some of them in the chat box. I'm going to hand over now for all the interactions to Pratap and Naren to go on. And if I'll have any questions, I'm also going to barge in.
Thank you so much, Dr. Mokhano. It was wonderful. I think I was talking to you before the session. People want to listen to clinical questions and discussions, and that's what you said. A great talk, and we have very interesting questions from the audience. You did mention about the first surgical episode is crucial, and the first question from the audience is, what's the size of the endometriotic cyst you would like to remove?
Thank you for the question. Firstly, one has to be sure it is an endometriotic cyst, and obviously personal experience and radiological experience will make it highly likely that it is an endometrioma if you connect with the clinical presentation. So in my mind, if you ask me what do I practice, let's remove any type of cyst, but not for the sake of removing the cyst, but for the sake of establishing a diagnosis, understanding the extent of the disease, and then being able to quantify the likelihood of becoming pregnant for the woman. So it's from the perspective of reaching a diagnosis and a prognosis for spontaneous pregnancy that one should offer a laparoscopy if they have the technical abilities to deal with whatever comes their way. Or if I find an endometrioma of 3 centimeters, would I say to the woman, no, you don't need surgery, please keep going? Okay, I might do it for 2 or 3 months if she has anovulation. I might do it if they're trying for 4 months. I might do it, but I would not do it for too long because I'm afraid that this endometrioma might be visible. She's stage 3, but it could affect her fallopian tubes. She might not have a very high EFI. Her likelihood to conceive will be minimal, and it's best to diagnose, treat, classify, and advise, and move on. These patients, the infertile patients, this is infertility I'm talking about, not symptomatic patients. The infertile patients would like something to, they first like to understand the diagnosis and then move on to achieve a pregnancy. So I'll operate on a 3 centimeter, absolutely.
Yeah, thank you so much. I think the next question by the audience is, you did mention about the indication for IVF like low reserve, tubal disease, severe endometriosis, and advanced age. The next question by the audience is, do you routinely do anti-Mullerian hormone in your practice?
It's the first test I do for women, the AMH. And if you want to ask me, I think there is a direct link between a low AMH and the presence of endometriosis. So if I see a patient that is young and she has no ultrasonographic image of endometriosis, she has no dysmenorrhea, but she has an unusually low AMH, my first thought is she has endometriosis, and she doesn't even know it. So I do AMH. The AMH is the new way to diagnose ovarian reserve, without a doubt.
Thank you. Naren, you have another question from you.
I quite agree with you. 3 centimeters, I would also go ahead and remove that endometrium because in 1 month it will become 4. And then you say the cutoff is 4. So then in 1 month later you'll operate. So be a little on, and of course AMH, yes. We also do an AMH as a routine part of our infertility workup. So again, someone has asked about not infertility related, about the deep posterior fornix nodule, tender posterior fornix nodule. So would you elaborate on that?
I think in terms of posterior fornix nodule, does this have an impact upon fertility? We don't know. But it sends a message that it is possible that this woman could have severe endometriosis. I think ideally you would like to investigate this woman with an MRI maybe. Should you operate on her if you have expertise in advanced endometriosis where you can resect rectovaginal endometriosis and so on, and you can work in a team of bowel surgeons and gynecologists? I think it's a good way to do both, to diagnose if the woman has infertility and at the same time remove the rectovaginal disease and then offer the woman suppression for a few months.
So here's another one, minimal endometriosis. We've run into a minimal endometriosis on the powder burns and the Allen Masters and the peritoneal gaps when we were doing for a tubal block, a laparoscopy. So should we go ahead and treat this also, fulgurate this like a paintbrush all over the pouch of Douglas, or leave it alone? Because this was undiagnosed. This cannot be diagnosed by any imaging.
So the way I understand it is if we find minimal endometriosis, stage 1, just a few areas here and there, and for the discussion's sake, it's not like you only find one type of endometriosis. You will have gunpowder endometriosis, you will have white lesions, you will have old scarred white endometriosis. So there are many ways this endometriosis presents. But if it's clear to me that this is endometriosis, I found it grossly unethical not to treat it if you have the tools. Because the first thing you're going to say to your patient, by the way, ma'am, I've just diagnosed you with endometriosis, but don't worry, it was just stage 1. It just, it'll be absolutely fine. That's not what medicine is about. It's about saying, I found endometriosis, it does affect fertility, I've lasered it, it's all gone, fulgurated it. I've checked your tubes, you're doing really good, and based on this score that I've just done, your chance to get pregnant in the next 12 months is 60%. Wow, thank you, doctor. Bravo.
Yeah.
So thank you, Edgar. You are on my side, and I'm next debate. Whenever I land up in debate, people say, "Don't touch it, don't touch a 3 centimeter, don't operate." So I have someone a very strong ally now who I can
Exactly.
quote in all my
I think that's a
arguments
nice
and
discussion
discussions
because a
with
lot
the
of
IVF people, especially.
yeah, I agree with Naren also because people operate unnecessarily. I think we got a nice conclusion by the statement of yours. But I think, Edgar, you beautifully mentioned about this fertility, endometriosis fertility index. I think that's a great paper you showed us about a couple of them. The question asked by the audience is, do you need to suppress endometriosis after surgery with generic analog? And what's your experience with Dynogest? Can you suppress the same thing for 3 months and then you do the IVF?
Answer to question one, should we suppress? I think I've showed you some evidence that it is beneficial. So if I find stage 3 endometriosis and endometrioma present that I could strip, I will always suppress. We have to acknowledge that even if you laser lesions, you will never get rid of every cell.
Yeah.
And endometriosis is a very invasive disease. It just listens to hormones and grows. So
Exactly.
once we have the evidence that it is beneficial, I think it's worthwhile using GnRH agonist for 3 months, and I use it routinely. Yet,
Okay.
I don't force my patients to take it. I say you have the option to take it, and you have the option not to take it. The risk if you don't take it is that endometriosis could come back very quickly, and then you're back to square one. And if you do take it and you become pregnant, because the likelihood to get pregnant will be a little bit improved afterwards, then you have 9 months of amenorrhea, bit of breastfeeding and so on, so you actually don't have time to reseed that endometriosis afterwards. So yes, I would encourage my patients with endometriomas to receive the GnRH analog. I
The
have
next
no...
supplement question is, do you wait for the next menstruation? You
I
suppress it.
do. I
Yeah.
do.
Do you wait for the next menstruation to come after 3 months, or do you directly start after 3 weeks after the last dose of the treatment?
No. If the patient is going for IVF, I think from my experience, starting immediately, she's so oversuppressed, the response is not good. So I actually tell them, wait for a period to start. That says that the axis has now returned to normality and is expected to do what we're asking it to do, to suppress the LH surge and so on, and then start her on treatment.
Yeah, that's interesting because some of us, I think, start after 3 weeks after the last dose of the therapy. And I agree with you that if they don't get their menstruation, they're completely suppressed. And I think we need a very high dose. Yeah, that's right. Naren, you want to ask the next one?
No, so there we have, yeah, because this one is just after me. Yes, she's made some ice cream and she's making me taste it.
Wow.
So various drugs we were discussing for suppression, GnRH agonist, Dynogest, the new Dynogest. And when we talk of Dynogest, it is being made now by almost 10 or 15 companies, each one claiming that they have the better molecule made better. And of course, the original made from probably Bayer or someone, they say that we are the original, we are the most expensive one. So is there a difference between these molecules made by different companies, or is just one sourced and it's just a marketing gimmick?
I confess I know my limits, so I would say from the beginning that I do not know the answer to this question. I don't use anything but GnRH analogs to suppress after
So
surgery.
that's an answer, very clear. GnRH agonists are the best, and Dynogest maybe for pain, but infertility, I think we can go in straight away after operating. It's minimal. Go with ovulation induction IUI or suppress for 3 months and then go for IVF. That's the thing. Yes. Do we have any other? Are you
Yeah,
posting the
yeah. I
questions?
think there are some lot of questions. I think you
Yeah.
definitely mentioned about the function is most important when the fimbria is very near the ovary. I think that's a very important observation by the observation on laparoscopy. And I think many people forget to see that. They just start doing IUI for somebody who has no fimbria there and everything is stuck. So you also mentioned about this cyst. My question next to you is, the does the bilateral ovarian cyst affect the pregnancy rates?
So bilateral endometriomas obviously is a severe form of disease. You're talking stage 3 to 4, depending what you find.
Yeah.
So any type of endometriosis of any stage will affect the pregnancy rate. I don't know if it's before IVF or in IVF. So treatment of endometriosis at the first surgery is the most important thing. It's very difficult to take a patient after she had 2 or 3 surgeries and make a decision, what should you do? Because she has already had partial stripping, maybe got some analogs, the cysts are back, they went back in, removed more. There's no benefit in continuing operating on these patients. It's far wiser to move them on, offer them an opportunity to have eggs collected and create embryos into IVF. So the more severe the endometriosis is, the higher the impact.
Yeah, that's great. The next question by the audience is, when you do a surgery for laparoscopically ovarian cyst, do you think the techniques are important? Like some people go and burn the ovary, some people put some sutures, and what do you think should be the best done to preserve ovarian reserve?
The first thing is to be as gentle as possible and to realize that the ovarian reserve is on the surface of the ovary, not inside the ovary. The stroma inside contains no follicles. The second one is that it becomes very clear if this is an invagination from outside in, or if this is a de novo endometrioma in a corpus luteum. So if it is an invagination, if you strip it clean, that's probably the best way to treat it. Unfortunately, the older the endometriosis is, the more difficult to strip, and you have to traumatize the ovary quite significantly. So I think stripping, if you can do stripping, is ideal, and seeing clear tissue remaining quite vascular, but it doesn't bleed. If you cannot do stripping, and all of us would have seen bad endometriosis with an endometrioma that is completely impacted on the bowel, the posterior wall of the uterus, pelvic wall, and it never ends. You can put your scope in it, and it's a huge, melon-sized cyst. They're impossible to strip fully, those cysts.
Yeah,
So
what I
case,
find is, what I find is, I thank you for the lovely explanation. What I find is a small cyst is sometimes difficult to remove than a bigger cyst, because a smaller cyst is kind of adherent to the hilum, and the bigger cyst is very easy to do. So when my team operates, I tell them the small cyst must be done by senior surgeons, and the big cyst can be done by the smaller surgeons. So lower, not lower or smaller, but the junior ones. Yeah. What do you think about that?
I think people need to get expertise and operate with good surgeons to learn the skills. And as I said in the beginning, you do have excellent surgeons in India, so I'm not afraid that the skill is not passed on. But if I have only one remark about the endometriotic surgery, I think the first and only rule is first do no harm. It's nearly impossible to explain to a patient that you had to remove her ovary because you ran into trouble by causing God knows what, shredding the ovary to pieces when you've opened it up. That's not something you would like to do. So if you cannot safely do the surgery, it's better to abandon and just give GnRH and move the patient either to a different practitioner or to fertility treatment like IVF.
Exactly. I love this statement saying don't do any harm. I think the Italian group of endometriosis has come out with a lovely publication on 10 don'ts, what you should not do in endometriosis. And I love that. Did you read that, Edgar, about
I
Italian?
confess I didn't, but I will now.
You should,
And you
because
should put it on the,
I
you
think
should put the
10
reference.
don'ts is something very interesting, and I love that. So, one last question before Jaideep. Of course, Jaideep would get the major question for you. And one other question from the audience is, we do find deep infiltrating endometriosis in our clinical practice, but it sometimes come with some shoulder pain and some appendicitis kind of pain. Do you think it is connected to this kind of a peritoneal fluid which goes round and round, and inflammatory processes which happens to cause the pain?
Mm, I'm not convinced it's the fluid. We are
Yeah, the
well
peritoneal
aware.
fluid. Yeah.
We are well aware that we do not know the
Oh, right.
proper pathophysiology of endometriosis, because if you have 3 theories to explain one disease, it means you have no idea what you're talking about. So retrograde menstruation, absolutely. Could it be coelomic metaplasia? Maybe, but I think that distance spread is definitely proven. So for
No, but I have
example,
found some people coming with shoulder pain, very severe
yes,
pain here,
mm-hmm,
and probably, and then sometimes from appendicitis kind of a pain. So do you think
yes.
that peritoneal fluid, when the endometriosis goes round and round and causes some kind of a pain there? So
No, I think they might have diaphragmatic endometriosis, which
yeah, that's
irritates
what I
the
thought. Yeah,
phrenic
yeah,
nerve and gets projected pain into the shoulder. But
yes.
think of examples where I had a patient that her mother brought her to me because she would have catamenial blindness in one eye.
Wow.
The girl would lose her eyesight every time she had a period. She had endometriosis in the retina, and she had hemorrhage inside her eye, losing her eyesight. So any disease that is ironically linked, related to a period in a young girl or a female of any age, we have to
Exactly.
think endometriosis.
Yeah,
Fits, having a fit every time you have a period, not normal. This girl will
exactly.
have endometriosis in her brain. So this is something that we need to be, I'm teaching my students, look, this is crucial for you to understand that if a woman complains of something that only happens with her period, it could be endometriosis.
Exactly. Jaideep, you have all
Yeah.
you have
Yeah, there's
big
so many
questions.
things going on in my mind, Pratap. Thank you for this opportunity. Edgar, today morning itself, I saw one patient who was like 37 years old and married for last 12 years. And she had a 5 centimeter endometrioma in her right ovary, and her AMH was just 0.7.
Wow.
Yeah.
So, so how do we go about it? What should I treat first, endometriosis or IVF or her infertility? I mean,
I
because
think that
12 years, low AMH with endometrioma.
I
The
think
other
that
ovary was like,
I would personally treat this woman with IVF. I would explain to her that she will have the opportunity, if she has no symptoms, which they normally don't, stage 3 and stage 4, they don't have symptoms.
yeah,
It's incidental finding on ultrasound. But I would propose IVF for her for one reason. She will have the opportunity to have treatment for endometriosis in the next 6 months or a year, but she doesn't have the opportunity to have a go at IVF. So if the other ovary is free of disease, she has some antral follicles, I think it's a good plan to just go in, pick up some eggs. You might say, I don't want to implant them. Is that okay? I might just do IVF, freeze those
yeah,
embryos, 3-4 embryos,
yeah,
then go in and treat the endometriosis, then suppress her, then give her 3 months of decapeptyl before the frozen cycle, and then do the frozen, because at that time there will be very little impact from the endometriosis, I think.
absolutely.
It might still
And
impact the quality of the eggs, but yes.
yeah. Another incidents where you have adenomyosis and endometriosis together, especially 35-year-old or so. And very recently I had seen a case where the uterus was almost as big as like 16 weeks size, with adenomyosis and bilateral endometriomas and infertility.
They are very challenging cases here. You're talking about very advanced disease. For adenomyosis, I've seen surgery done, and many of your colleagues do adenomyosis surgery, where they open up the uterus and remove the adenomyosis. Nowadays, I understand there are some ultrasound machines that you go in and you have ultrasound beams treating the adenomyosis. But if you don't do any of those, the only thing is long-term suppression for 3 months, trying to shrink the aggressiveness of endometriosis and maybe do IVF. The issue is the environment in the uterus. Even if you get embryos, that adenomyotic uterus is so aggressive in terms of, you think about this delicate event of us completely shutting down our defense against an embryo, which is non-self, to allow it to implant, and the adenomyosis creating a world of havoc in that environment. It's difficult. I had a few patients with adenomyosis, and they're the most difficult to treat when they have large uteri.
Yeah, that's
Especially
interesting.
in this case, like, she had bilateral endometriomas also, plus age. So, what is your take on using donor eggs for these patients? Because her AMH was also very low.
I was just going to say, if her AMH is good, I'll stimulate her. But if her AMH is very low, I think donor eggs is a good place. Yet, we do have good evidence of both scenarios. Women that are donors that have endometriosis, their egg quality is lower than if they didn't have endometriosis. And also, women with endometriosis receiving a very good quality embryos have a lower chance to get pregnant compared to women that receive good embryos but themselves don't have endometriosis. So such a patient is already at a disadvantage just because she has the disease she has in her uterus. So there could be the possibility that you offer this patient maybe surrogacy and consider stimulating her, where you say the closest you will ever be to having your own child is maybe obtain an embryo and we put it inside a woman that has no endometriosis, hopefully to improve the likelihood that you can get pregnant. Or if that's not possible and the MH is very low, then you can just consider, as you said, receiving eggs from another woman and implanting them into her uterus.
Yeah, I think Jaideep, I think the younger the woman, I think probably will be a better oocyte quality compared to the age advantage. But I think endometriosis just spoils the egg anyway. So
Yeah. I just wanted to relate to you one story. When I was very young, we just started IVF. And there was a bus driver who could hardly afford IVF at that point of time. He brought his wife, who was already in her late 30s. She was about 39 years old. And she had adenomyosis as big as 20 weeks. And I was thinking, like, I was very young at that time. I said, oh God, where am I lost? She was brought with somebody whom I knew. So I started suppressing her with analogs. I'm talking of almost 25 years back. And after 3 analogs, the uterine size came down to about 16 weeks or little lesser. And I told him, I said, it's no good. Please go and adopt a baby. At that time, anyway, surrogacy was out of his scope. He got very angry with me. He said, because I told you that I'm a bus driver, you don't want to take my case up. So I gave her another 2 shots of analogs, and I was actually forced to do an IVF on her with egg donation. And can you believe it? That lady has twins who are almost about 24 years old today. So sometimes, and I was just thinking, like, even today, I would have never taken a chance.
yeah, exactly.
So it's unbelievable, but I mean, it happened. So that's
Miracle,
life. It teaches us so
miracle,
many lessons. Pratap, you
miracles.
have some more questions?
No, I think we answered all the questions from the audience. And Dr. Edgar Makano, you were very practical in your talk, and that's what all of us are appreciating. You'll be surprised that we have more than 1,500 people listening to us, and it's a great number. And Acumentis, Harmonica has done a great job in marketing your talk to a lot of people in India and otherwise too. And it's a great talk. And Jaideep and Narendra has been
Yeah. So
they're
thank
my
you so
best
much.
friends.
Yeah,
That's
Pratap.
good. Yeah.
Thank you
Yes.
to both, and thank you to all. It's a pleasure being here. And I look forward to my next trip to India soon,
Yeah, looking
hopefully. I
forward.
hope you're all well and
Looking
in India.
forward. So
Thank you.
thank you everyone. It was just wonderful. You know, we are getting so many insights and so many newer thought processes. It's been a wonderful, wonderful platform where we have, you know, together learned so many things from each other's experience. It's not only evidence, but experience only creates evidence, and that is something which we need to understand. So we must document whatever we are doing, and whether it's a negative or a positive result, it should be documented and discussed. I'd like to put on record my sincere thanks to Dr. Edgar Mocano for his wonderful, wonderful deliberations, to Yvonne, my dear friend, for this wonderful opportunity to conduct this masterclass, to my both chairpersons, very, very dear to me, both of them, Pratap and Naren, for really, you know, making it so interactive and great discussions in every session. To Acumentis, Shubhajit, and the whole team, and DocMode, especially for the platform and also being a bridge between all the Indian doctors and all over the world. I'm sincerely looking forward to the next two masterclass lectures. And as you're all aware, every one of you will get a nice certificate at the end of this whole masterclass, which will be duly signed by our FIGO chair and us. And if you have anything else on mind, do write to us. Looking forward to future further interactions. Thank you very much. God bless you all. Have a great day and a great night.
Thank you very much for your lovely talk, Dr. Edgar, and Jaideep for inviting me to chair this session,
Thank you.
And Subhajit from Acumentis for inviting me too. Bye-bye.
Pleasure meeting.
Bye-bye.
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 Good night.
Bye-bye.
Good
Good night.
night. Bye-bye.